Good morning, my name is Riley.
And I'm Liv.
And this is our presentation on Health Psychology Part 1.
So what is health psychology?
Health psychology is the study of how biological, social, and psychological factors influence health and illnesses.
Okay, so one of the biggest aspects of health psychology is doctor and patient interactions, and McKinstry and Wang in 1991 used nonverbal communication in a study to investigate whether the way a doctor dresses plays a role in how patients perceive them. Their sample was 475 patients, 67% were female, and then they had 30 doctors in the study. And then there were 5 locations used, which were in Lothian and Scotland. And then it was measured on a 0 to 5 point scale, and a closed questionnaire was used after the study was conducted. And then over here, this is just like a display of the doctors that were used. It's kind of hard to see.
The results of the study were statistically significant, with 41 of the patients saying that they had more confidence in the ability of the doctors based on their appearance. The statistics show that the doctors in a smart suit were the most popular, as they presented themselves professionally. The doctor in a cardigan and casual pants scored higher than the doctor in jeans, and informally dressed female doctors were scored significantly lower than the other female doctors. The other results were other patients were more likely to give higher scores to formally dressed doctors, and older patients were more likely to give female doctors in a white coat a higher score.
So another study dealing with patient and doctor interactions was McKinley, but instead they used verbal communication in 1975 to investigate the comprehension of medical terminology in a sample of participants who were pregnant using a maternity service. The sample was 87 families. And each family was interviewed 4 times in an 18-month time period. And then they had 13 chosen words for each family. And the words were medical terminology that they may or may not be familiar with. And then over here, this is just their scores. So score A being that they did not, the patient did not recognize the word or understand it. And then score D, the patient had a good idea of what the word meant. And then these two are just like in the middle. And then after that, a year later, they did a follow-up with a different set of doctors, but the same patients and the same words. And then they were split into 2 groups, utilizers, which meant they did understand the words, and underutilizers, which means they did not understand the words.
The results of the study found that for almost all the words, the utilizer group had a significantly higher score than the underutilizer group. In conclusion, people who use medical services frequently have a better understanding of medical terminology. It also found that doctors underestimate the level of knowledge that patients may have of medical terminology. And then over here we have the graph of 13 words that were used in segments of underutilizers, utilizers, and physicians. And then here are the answers. Either they had no knowledge of the aspect, they attempted to have knowledge, but it was either wrong or vague, and then adequate knowledge.
Another important aspect of health psychology is diagnosis style. Serafino played a big role in this. She had multiple studies. One of her studies from 2006 found that it was hard to diagnose a patient when the patient criticizes the doctor, becomes angry, ignores what the doctor is saying, insists on more tests and medication when a doctor finds it unnecessary, or makes sexual remarks to a doctor. Doing any of these things can cause like a gap between the doctor and the patient's relationship that can make it hard to really figure out what's wrong with them. And then over here, Serafino also found that patients interpret symptoms differently from each other, and some patients tend to downplay their symptoms that point to major illnesses. So if a patient can tell that they themselves are sick, they might make it seem less than what it actually is, because they could be scared of the treatment or the symptoms that come from the treatment. And doctors also have to take into consideration that everybody's different, and so some patients might feel something more strongly than another patient.
Another part of diagnosing patients comes with different types of errors that can occur. Although it is rare, there are occasions when a doctor will get something wrong due to either misinterpreting their patient's symptoms or a patient not being completely open about what they're experiencing. When this does happen, the errors are classified into 2 groups. There's type 1 errors and type 2 errors. Type 1 errors are when a doctor diagnoses somebody as ill when the patient is healthy. An example of this is a male being diagnosed as pregnant. Obviously, this can't happen, which makes it a type 1 error. A type 2 error is when the doctor diagnoses somebody to be healthy, but in reality the patient is actually either physically or psychologically ill. An example of this is an individual with COVID being told that they don't have COVID. A type 2 error is considered to be the most dangerous thing due to the effects of not treating an illness, as this can lead to death or other complications.
So, along with diagnosing style, practitioners also have different styles of the way they communicate with their patients. Every doctor is different, and Byron and Long studied this. This was in 1976. They analyzed over 2,000 previous medical consultations. While doing this, they discovered two different styles of communication between patients and doctors. They also found other ones, but these were the two main ones. One of these was the doctor-centered style, which was strictly like just around the doctor speaking mainly. The doctor asked the patient yes or no questions. It wasn't really open-ended questions like how are you feeling or anything like that. It was very cut and dry. Also, any attempt to expand on a question by a patient was ignored. Like again, like they didn't really ask questions, and they probably didn't feel comfortable enough to because it was so short. And it was also based on fact and no communication. It was strictly like medical. It wasn't really asking like how a patient was feeling or how it affects them in any way. And then the complete opposite is patient-centered style, which this is more between the doctor and the patient together. The doctor would ask the patient open-ended questions so they could talk freely. It wasn't very strict. It was very free and calm, just like a normal conversation between two people. And the doctor also limited the use of medical terminology because it would make the patient probably more uncomfortable because they might not understand everything the doctor's saying. They don't want to feel stupid compared to a doctor, so sometimes they'll downplay how they feel. But the doctor also encouraged the patient to express themselves so they could tell them how they were feeling. Like it wasn't just strictly about medical, like how stuff made them feel, how different treatments made them feel, how their symptoms made them feel. It was very open-ended, and it creates a relationship between the patient and the doctor, which helps the doctor and the patient both because they're able to understand what they're going through.
The key study for this section is by Savage and Armstrong, conducted in 1990. The context behind this is that there's been a long-term debate between which consulting style is best for a practitioner to use when dealing with patients. There are two styles. There's the sharing style and then the directed style. The sharing style, which is otherwise known as a patient-centered style, is when the doctor allows the patient to be involved in the decision-making process. Some patients may prefer this because they get a say in their treatment plan, and it may also make them more compliant as they can pick what they want to do and stay more comfortable with what will happen. And then the directed style, otherwise known as the doctor-centered style, is when the doctor takes full control of the decision-making process. Some people may prefer this because they know the doctor has more knowledge on it as they went to school and studied on this topic. They may also like the doctor's authority over them, and it could lead them to make better decisions on their health. The aim of this study was to compare the effects of directing and sharing styles of consultation on patient satisfaction with the consultation.
Okay, continuing the Savage and Armstrong Key study in 1990, the sample consisted of 359 patients. They were teenagers all the way to older individuals, so 16 to 75. It was a wide selection. They were randomly selected from an inner London general practice. Each participant either received direct or sharing style consultation, which Riley had went over earlier. 4 of these participants had refused to participate in the study, and 5 of them were excluded from the study just due to it not working out, the consultation not being clear. And they all had presented at least one symptom of an illness at a consultation. If they did have a life-threatening condition, they were excluded just so that the results were fair and also no distress to the patient. And for the design, an independent observer listened to 40 audio recordings of the consultations, and he just clarified that they were the certain style that they had claimed, so either patient-centered or doctor-centered. And then measures, there was a 5-item questionnaire that was completed by each participant immediately after the consultation and then taken a week later, and the questionnaire was just asking like how they felt about their consultation, like if they were satisfied with it, if they fully understood it or not.
Alright, so for the procedure of this study, the participants were selected through a random number generator, and this generator selected about 4 patients per surgery, and it lasted over a 4-month-long period. Savage, the conductor of the study, had a random deck of cards that gave each participant either the directing style or the sharing style. He did not know which card the participant received until they showed up for their appointment. There were about 5 prompts on each card for the chosen style in case Savage got confused on what to say or he didn't know how to prompt the conversations. And after the consultation, the participant completed the measures, so the 5 question questionnaire. And then over here we have a graph that shows the parts of the consultation. So judgment on the consultation, their diagnosis, the treatments, the prognosis, and then the follow-up and closure. And it shows each style of consultation, the prompts that the doctor had to give. For the directing, there's about 1 in each category, and then sharing, there's more than 1. So there were options to choose from when prompting each appointment.
So continuing the Savage and Armstrong study, the results. So the directing style was found to be perceived as giving a much better explanation than the sharing style did. To back this up, 45% of the directing style group and only 24% of the sharing style group felt they received a good explanation. And again, 62% of the directing style group and only 37% of the sharing style group felt they had a complete understanding of their health issue. So obviously the directing style group was a lot more successful than the sharing style group. And then over here, so this is the questionnaire. So they were asked to rate how they felt about the question or about the study, their consultation. So I was able to discuss my problem well. I received an excellent explanation. I perceived a general practitioner to have complete understanding. I felt greatly helped, and I felt much better. So the directing style had higher percentages for all of these, except for the last one, which said I felt much better. The sharing style had 3 more points than the directing style, but other than that, the directing style had passed it. And then also they had been interviewed again a week later, and it was found again that 39% of the directing style had felt the same, and 18% of the sharing style had felt the same. So still, the directing style had passed the sharing style. So it would appear that a more direct style of consultation brings about more satisfaction to patients.
Okay, so the next section in health psychology is the misusing of health services. Safer et al. In 1979 created a model that explained why patients delay seeking treatments. There are 3 stages that they created, which was appraisal delay, illness delay, and then utilization delay. Appraisal delay is the time taken for a person to interpret physical symptoms as an indicator of illness. This could be affected by immediate sensory information such as bleeding. Bleeding is obviously something that will target your brain to make a quicker decision and seek help quicker. Illness delay is the time it takes between people recognizing that they're ill and actually seeking some form of medical attention. This can be affected by familiarity of the symptoms, so if the person is comfortable with the symptoms and experiences them frequently, then they won't seek help as quick. But if it's a new symptom, then it might scare them into seeking treatment. And then utilization delay is the time taken between deciding to seek medical attention and actually doing so. This can be affected by multiple factors, one of them being cost. If the person doesn't have enough money to see a doctor, then they will wait longer too. And then the severity of their symptoms will affect that as well. And then another study conducted by Becker and Rosenstock in 1979, they created a health belief model that attempts to predict when people will make rational health decisions. It assumes that people will change their behavior in the following situations: perceived vulnerability, when a person believes that they're more vulnerable to the symptoms that they're experiencing, and then perceived severity, if the symptoms are really bad and they think that it'll affect them in negative ways. Perceived benefits, if the person thinks that they'll benefit from seeking treatment. Perceived barriers, if a person obviously doesn't have as much money, then they might think that's a barrier. Cues to action, so if a person thinks that they'll lose their health quickly. Self-efficiency, if they think it's efficient to go to the doctor than waiting. And then modifying variables.
So continuing with misusing health services, an extremely common syndrome would be Munchausen syndrome, which is where it's a disorder where an individual intentionally fakes or induces symptoms of an illness or injury in order to gain attention. So not necessarily faking a cold, it's more intense things like faking cancer, and then malingering, which is almost the exact same thing. However, you aren't diagnosed with it. It's just something you do. Like, it's more of like a pleasure thing. Folks and Freeman studied this carefully in 1985. And while doing this, they had found 3 essential features of Munchausen syndrome. One of these would be recurrent or simulated illness present to a doctor. For example, this could be explaining like how you have the same symptoms over and over again. You go to the doctors constantly saying that you're sick, or lying and saying your symptoms have gotten worse. This one, I don't know how to say that word, but that's just wandering around. Like, you might see somebody wandering around a hospital just very strangely, like wondering what they're doing. And this is pathological lying. Could be lying about their symptoms, lying about what had caused their illness, multiple things. And these features focus on actual evidence, like tampering with test results or inflicting symptoms onto themselves. Like, for example, like punching a wall and saying you broke your wrist or your knuckles, or tampering with test results, putting things in your test results to make it look positive or making it look negative, can all be things that are actual evidence of Munchausen syndrome.
A case study of Munchausen syndrome was conducted by A Lame in a Dream in 1995. They ended up studying a 22-year-old female university student who had been presented with a potential immune deficiency. She experienced painful swelling over her right breast for about 5 days before entering the hospital, and also claimed to have about 20 previous abdominal wall swellings. The doctors thought that she had deep vein thrombosis with what she presented, so she was prescribed oral contraceptives and warfarin. These didn't work, and she was hospitalized, and then began to complain of painful swelling in her groin. She had scarring from previous swelling, but test results kept coming back normal. And after this, she had developed another breast lesion, which needed to be surgically removed. Doctors could not find a reason for this lesion, but they put her through a psychiatric assessment, and she ended up being very defensive. When she went up to use the bathroom for this assessment, the nurses found a syringe of fecal material near her bed. After being confronted, she became very angry and left the hospital. She mainly did this for the attention that she received from the doctors. Her being in the hospital gave her care and constant attention, so the syndrome that she has pushed her to do that.
So another case study of Munchausen syndrome, Zibis et al. In 2010 found a 24-year-old woman who had a painful right hand and arm. She had claimed to have 4 previous operations on the same arm. She developed a fever temperature while in the hospital, but any test couldn't locate an infection. Doctors found this strange, but continued to keep her in the hospital. She was seen reading medical books, specifically about her region that claimed to have caused her pain. And she'd also been seen punching walls, which was odd, claiming that you have an arm injury and you're punching walls. The doctor stopped her treatment once they had seen this, and after 20 days, her arm was free of surgery. Another case study similar to this was Fadia et al., which was in 2012. She had studied a 40-year-old woman who had injuries to her right leg. She had complained of arthritis on her right leg previously. She had headaches, she claimed, and also ulcers. During her hospitalization, her condition got worse, and she could no longer walk. But tests showed nothing wrong with her leg, so this was obviously suspicious to them. She had an x-ray and was taken. She had a sewing needle in her leg. So she basically just placed a needle in her leg in order to cause her pain so she could not walk. And so when doctors found this out, she was questioned. She became very aggressive and tried to jump out of a hospital window. Luckily, she was okay and had left the hospital after this. But as Riley said, Munchausen syndrome causes these patients, causes them to continue to lie about their symptoms, lie about being in pain because they get attention from these doctors, and it makes them feel cared for, and that syndrome does push them to do that.
Okay, now on to the types of non-adherence. Non-adherence is the failure to follow prescribed medical recommendations. Clark studied this in 2013, and they noted that different types of adherence can be reversed to learn about different types of non-adherence, such as not following short-term advice, so a doctor recommending that a patient take pills to improve their condition, not wanting to make lifestyle changes, so maybe stopping smoking so that they improve their health, failure to attend follow-up appointments, and then not engaging in preventative measures such as contraception. Serafino studied this in 2006 as well, and it found that 40% of the population, so about 2 out of 5 people, fail to adhere to medical advice given to them. This research showed that when medicine needs to be taken for short-term illnesses, adherence climbs to 67%. This is because patients feel as though it's a shorter amount of time, so it's less of a burden for them. And then for long-term illnesses, it drops to about 50%. This is sometimes people forget, and that causes them to take their pills, and then people tend to adhere more just before or after seeing a doctor. And it appears to be little adherence for advice involving lifestyle changes. And then Serafino in 2006 also noted that these could be overestimates, and the data fails to appreciate the range of adherence.
Okay, so continuing with the non-adherence, when patients don't adhere to their prescribed drug instructions from a doctor, different problems could occur, and some of these could be their health condition not improving. If they're not taking their drugs, they might become more ill or gain another illness if they're not taking drugs. And then drugs that they haven't consumed, that could be lying around the house, like a child get a hold of it, which would cause a lot of other problems. Financial costs, if a drug is too much or too expensive for somebody to afford, then they'll convince themselves they don't need it. And then with rational non-adherence, this is when patients believe that they're making rational choices about their medication. Like, usually they'll create a cost-benefit analysis in their mind that convinces them it's okay to not adhere to medical advice. They'll do pros and cons list of the medicine, and in the resulting, like, in them not taking the medicine because they truly believe they don't need it for whatever reason. Laba et al. Studied rational non-adherence in 2012. She wanted to understand rational non-adherence using a sample that came from Australia. Patients were given an online survey that wanted to estimate the importance of 8 medication factors that'll determine if they want to take a medication or not. A couple of these are immediate medication harm and benefit, so as soon as they take the pill, how fast the benefits will come, and also the harm from it. Long-term medication harm and benefit, symptoms that are going to stay with them for a long time, or the benefits that are going to stay with them for a long time. The cost argument, which just consists of how expensive something is, how that's going to affect them. The symptom severity, how severe their symptoms will be, and alcohol restrictions, they won't be able to drink if they're taking a certain medication. But 6 of these factors showed that it affected the choice of rational adherence, and the two that were not were symptom severity and alcohol restriction.
So for measuring non-adherence, a method to do this is through clinical interviews. This is a dialogue between a psychologist and a patient to discuss issues that are going on and why they may not be taking their drugs or what they're doing. Butler et al. Investigated this in 2004. They used a clinical and a semi-structured interview to analyze 58 patients about immunosuppressants who had undergone kidney transplants. There were 3 outcome measures from this experiment. First was electronic monitors. They used this to look at the patient's vitals and how they were reacting to this. A self-report questionnaire, which they took at home. It was questions about the illness that they had and the drugs that they were taking for it and their kidney transplant. And then a semi-structured interview between a doctor and the patient. This followed a set of questions, but if the patient started talking about a different topic, the doctor allowed it to kind of get to know more. And then an assessment of depression using the clinical interview schedule. This is a CIS, and it just asks questions about how they were doing themselves and how their body was reacting. And the electronic monitors found that 12% of the sample missed about 20% of medication, and 26% had missed 10% of the medication days. The questionnaire and semi-structured interview found that 2 main factors of non-adherence were beliefs about the medication and the negative emotional impact that they had.
Okay, so continuing with measuring non-adherence, Chung and Naya in 2000, they used the track cap to study compliance with medication. A little bit of information about the track cap. It works by counting each time the lid is taken off. And if the lid is taken off in multiple times in 1 minute, it's not counted. And after 15 minutes, if the lid is still off, it counts as an additional time. But they tested the compliance with treatment using an oral asthma medication using a device called the track cap, which we just went over. And the sample was 57 participants. They were aged 18 to 55, so teenagers all the way to elderly people. And the treatment had lasted 12 weeks. But they weren't aware that the track cap was keeping record of how often they were taking their medication. But the median adherence rate was 71, and the median compliance rate was 89. So after that, they had concluded that the track cap could be a reliable method to measure compliance and adherence.
So another method of measuring non-adherence are blood and urine tests. These tests are direct measures of adherence because it can measure the level of the medication in your bloodstream. So if it's present, then the doctors will know you're taking your medication, but if it's not present, then it's clear that the patient hadn't been taking their medication. Roth and Kieran studied this in 1978. They used biochemical analysis to examine the accuracy of patients' statements on the consumption of the antacid that they were given, and it was used to treat peptic ulcers. So they were given about 36 bottles of this medication and a measuring cup. They were told to take 1 ounce of it every 4 hours for 4 days. The mean of this intake from the sample was about 47%, and their estimated intake was 87%. For adherence in children, this was studied by Watt et al. In 2003. They reported a new asthma spacer called the Funhaler. The study used 32 children, ages 1.5 to 6 years old, and it targeted this demographic because it was made to make taking their medicine fun, therefore they would want to do it. The children's parents were asked to give the children the inhaler, and a questionnaire was used after to investigate whether they had taken it or whether it had not worked on the kids. 38% more parents medicated their children on the previous day with the Funhaler compared to the standard inhaler, and 60% more children adhered to the recommended dosage with the Funhaler compared to the standard inhaler. Therefore, they concluded that making medicine fun would make people want to take it more, and yeah.
Okay, so moving on to individual behavioral techniques. One of these would be contracts, which are written or verbal agreements between a patient and a doctor. These would be agreements about what the doctor and the patient are going to do in order to treat the patient's illness. The patient commits to a set of behaviors that the doctor finds fitting for their illness, whether it's lifestyle changes, like going to the gym or eating healthier. And Bosch Catwitch in 2007, he conducted a review of previous studies that had used contracts in illnesses. He did report that contracts did improve adherence. However, there was very little evidence to support this, so it's not fully trustworthy, or you can come to a conclusion about it. Another thing with individual behavioral techniques is customizing treatment. Not everybody's the same, so one method fits all technique isn't going to work. Patients take symptoms differently, illnesses affect them differently, so healthcare workers should figure out what's best for each individual patient. They should take into consideration lifestyle, their working hours. Some people work days and some people work like in the middle of the night. Allergies, everybody has different allergies, things they're allergic to, and exercise levels. Obesity is something that should definitely be taken into consideration when taking medicine.
Key study for this section was Yoelke and Glenwick, which was conducted in 1984. So for context on this study, behavioral technology was created in the 1980s, about when technology started to increase. And it's been successful in health promotion. So we see this today in ads for quitting cigarettes or taking like driver's tests, not using phones on your driver's license. It's mainly social media and like websites pushing for this one thing to happen. And this study used it. Their aim was to investigate the effectiveness and impact of 4 different behavioral technologies. And it was on the immunization rates of preschool children. The sample for this was 1,133 families with immunization deficient children. And so the procedure for this, the children were randomly assigned to one of 6 groups. First group was general prompts, so they received a mail sent to their house about just the immunizations that children needed at the specific age that they were. The client-specific prompt, they received mail again, but this time it was addressed to their specific child, and it told them what immunizations they needed and what they hadn't received yet. The specific prompt followed that, but it also said that it said what clinics had what immunizations and what days they could get access to this. The specific prompt with monetary incentive, they were offered about $175 in cash prizes if they got their child immunized. Contact control, it's just where the parents received a phone call about the immunizations their child needed, and then no contact controls. This was about the group that didn't receive anything, and they were just seeing if their child got the immunization or not. The measures for this, there were 3 main dependent variables. The first one was the number of children who received 1 or more inoculation at the clinic. The second was the number of children who attended the clinic. And the third was the total number of inoculations received by the children.
So continuing with Yoakley and Glenwick in 1984, the results were that all intervention attempts produced evidence of improvement, some more than others. For example, the specific prompt with monetary incentive produced the largest effect because you're giving somebody money and encourages them to do something more if they're getting something for it. A relatively inexpensive approach to increasing immunization is monetary incentives, because as long as it's not a extremely large amount of money, it is doable for people to encourage somebody to do something that they want.
All right, that concludes our presentation. Thank you guys for watching.